Heart failure is one of the most common causes of hospitalization in older adults. And the period following hospitalization is one of high risk, where patients are commonly readmitted or die. We sought to determine whether certain healthcare services could help improve outcomes following hospitalization for heart failure. And we began with a network meta-analysis that compared the effectiveness of different transitional care services that help patients transition from hospital to home. And we found that nurse-led home visits, heart function clinics, so multidisciplinary disease management clinics, and case-managed approaches of care improved outcomes relative to other services following hospitalization for heart failure. And we bundled these services together and incorporated patient input to deliver them in a patient-centered way. And the purpose of this study was really to implement these services among real-world patients hospitalized for heart failure. We recruited 10 hospitals and delivered services across hospitals among patients hospitalized for heart failure, titrating services to risk so that the highest risk patients received the most augmented services. And we sought to determine whether these services that have been shown in clinical trials to be efficacious could be effective among real-world patients hospitalized for heart failure. We used a stepped wedge cluster randomized trial design that is perfect for implementation because it allows for all clusters, or in our case hospitals, to receive the intervention, but it entails robust methodology where hospitals cross over to the intervention in a randomized sequence. And this occurs at intervals, such that at the start of the trial, none of the hospitals are receiving the intervention. And then at monthly intervals in our case, each consecutive hospital crossed over to receive the intervention. But the sequence within which they started was randomized. And we recruited all patients who were hospitalized for heart failure without being highly selective. We had no criteria that were age-based or comorbidity-based, nothing that was restrictive regarding left ventricular systolic function. We wanted to offer services to everybody hospitalized for heart failure. The only patients we excluded were those who died during hospitalization and those who were discharged to other hospitals. And so all patients who met eligibility criteria were offered nurse-led services that included self-care education, early follow-up with a family physician, and patient-centered discharge summary with action plan titrated to the symptom, involving patients' family members in this care. And then high-risk patients received home care, so nurse visits that followed our algorithm of care, and also services in disease management clinics for a minimum of 4 to 6 weeks following hospital discharge. Our primary outcomes were composite all-cause death, readmission, and emergency department visits at 3 months, and then composite all-cause readmission and emergency department visits at 30 days. And somewhat unusual for clinical trials is that we also measured patient-reported outcomes. So we looked at scores of discharge preparedness, quality of life, quality of the care transition, and then quality-adjusted life years, which is a combination of lifespan weighted by quality of life. We measure the clinical outcomes across all 10 hospitals and the patient-reported outcomes in a subset of 8 hospitals. So that's a summary of what we tried to accomplish in the conduct of the trial. Unexpectedly, we found that the services that are efficacious in the highly selective population of clinical trials was not effective at improving the primary clinical endpoints. So for the all-cause death, readmission, and emergency department visits, our hazard ratio was 0.99, so a slight trend to favoring the intervention, but certainly not statistically significant. And for the 30-day composite outcome, the hazard ratio was 0.93. Again, a trend to benefit of the intervention, but not statistically significant because the confidence interval spanned 1. The only component of these composite outcomes that improved was the time to first emergency department visit. But it was really a small group of patients that benefited in that regard. The patient-reported outcome measures, on the other hand, improved for the most part. So there was a significant improvement in discharge preparedness, care transition measure, and in quality of life, but no significant improvement in quality adjusted life years. So there are 2 take-home points from this trial that impact care and also impact research methodology. One is that results from clinical trials that are highly selective are not often generalizable to the wider population of patients. We, unlike the routine clinical trial, were very broad in our selection of patients. So we included patients who had complex comorbidities, including dementia. They were patients who did not have a fixed address, patients with language barriers, and those who couldn't really adhere to the services, but that represent real patients who are hospitalized for heart failure. And so the results that we expected were not results that we found, but perhaps we should have expected that they wouldn't be as much of a clinical benefit. But importantly, patients perceived a benefit and reported that they felt much more comfortable regarding their discharge plan. They had better quality of life, and the quality of care was perceived to be better. On balance, however, the data at this point does not justify the expense of these services in the non-selective populations that we included in our trial. And so moving forward, it would perhaps behoove us to first look at longer-term outcomes to see if there might be a benefit, and also to do a cost-effective analysis, because certainly patient-reported outcomes are important and may justify the services. But at this point, we don't know what degree of improvement in those outcomes are good enough to justify the investment. So the applicability is that many jurisdictions include some of these services at the hospital level, assuming that they improve readmissions and reduce costs of care. But those assumptions may be ill-founded based on data from this trial.